This is a review for ventricular dysrhythmias. We'll just go over the basics. This is not a substitution for your online lessons, so be sure that you go and spend time reviewing those. So let's talk about PVCs. PVCs are premature ventricular contractions. We do not count these as part of the heart rate, and the reason I teach that is I have no idea if this PVC produces a pulse. It may. If it does, it may be much weaker, so we have no idea. So I typically say you don't count it as part of your heart rate. What you can do is actually just look at a 3-second strip to kind of determine your heart rate. So your rhythm is irregular because of the PVC, and PVCs are wide and bizarre. That's the easiest way to think of them. The rate is whatever the underlying rhythm is, so you can have them in sinus rhythm, sinus tach, sinus brady. You can have them in AFib and atrial flutter. There's really no P waves associated with the PVC, and the QRX complex is wide, greater than 0.12, which is 3 small boxes, and it is abnormal in shape. It's wide and bizarre. So if we just have one PVC, we don't typically treat that. Multiple PVCs and frequent PVCs is usually defined as more than 6 in a minute, are treated with antidysrhythmics, and our most common one is amiodarone. So let's talk about types of PVCs because we do describe these with lots of words. So unifocal, which means they all look the same. So in this first strip, I have 2 PVCs, and they are unifocal PVCs because they look the same. They are coming from the same area in the ventricle. Multifocal means they look different. So one will point up and one will point down, and that is multifocal, which means you have more than one area of the heart that's irritable, and that is much more concerning than unifocal. Bigeminy means every other beat. Trigeminy is every third beat, and a couplet is 2 together. And so we have 2 examples of couplets. We have a multifocal couplet and we have a unifocal couplet. The more PVCs you have, the more concerning that is. If you have 3 PVCs in a row, that is actually, it can be called a triplet, but it does meet criteria for being called VTAC. So we have unifocal PVCs with sinus rhythm on the first strip. We have sinus tach with a multifocal PVC couplet. We have sinus tach on the third strip with a unifocal couplet. And we have trigeminy every third beat. 1, 2, 3, 1, 2, 3, 1, 2, 3, trigeminy. All of these would need to be treated. If these are the only 2 PVCs that my patient has, I might not need to treat, but the rest of these would need to be treated. There are many causes for PVCs that you do need to know about, so be sure you look in your online lessons. So let's talk about what VTAC is. So VTAC is wide and bizarre, so you've got a really good example of that. It's usually regular. The heart rate's anywhere from 140 to 250. And it may or may not have a pulse. So it's important to go assess your patient, and it is treated differently if you have a pulse and if you don't have a pulse. There's really no P waves associated with the VTAC. There is not a measurable PR interval, and they're wide and bizarre, so your QRSs are greater than 0.12. Treatment is amiodarone. If the patient has a pulse, we will cardiovert them. You always cardiovert somebody with a pulse. If they are pulseless, then we will defibrillate them. You defibrillate someone who is dead. VFib. VFib means my ventricles are quivering. There is no cardiac output. Your patient is dead in VFib, so your patient's not going to be talking to you. There's no P's, there's no QRSs, there's not a rate, you don't have a pulse, and we treat it. We start CPR, we'll defibrillate, we'll give amiodarone as our antidysrhythmic. Asystole, you do need to confirm this in 2 leads. So the strip I found for you is VFib into asystole. We do not shock asystole because there's no electrical impulse to shock. The reason we shock VFib is to stop this chaotic rhythm, and hopefully something less chaotic will come back. So if you see a systole, you do need to confirm that 2 leads and make sure that your patient didn't pop off. Asystole has no pulse, so if your patient's talking to you in asystole, it's probably not true asystole. There's no P waves, there's no QRS. We start CPR, and our only treatment is epinephrine, and to find out why they are in asystole and fix that underlying cause. That's your quick review. Thank you.